am Dr Mukti, bhavsar, second year resident in radiology department at Shah Medical College and Hospital, and I am here to present an interesting case. A 40-year-old female presented to radiology department with complaints of right-sided hearing loss, gradually worsening over years, throbbing right side unilateral headache, nausea and high-pitched ringing in right ear. On examination, patient was unable to hear normal frequency sounds. Non-contrast CT revealed a well-defined isodense lobulated extra-axial mass lesion in right cerebellopontine angle, causing mass effect in the form of compression of right middle cerebellar peduncle and contralateral midline shift. However, fourth ventricle appears normal and no signs of obstructive hydrocephalus were seen. On post-contrast inclusion, the lesion showed homogeneous enhancement. Patient was further advised MRI brain plane plus contrast for further evaluation. MR brain plane study revealed an extra-axial ultra-signal intensity lesion in right cerebellopontine angle which appears hypointense on T1 weighted images, heterogeneously hyperintense on T2 weighted images and fast flare images. Post-contrast MR study reveals intense homogeneous enhancement with evident extension of lesion in right internal auditory canal with intracanalicular extension causing its widening and erosion. Eventually, the diagnosis of vestibular schwannoma was established on the basis of clinico-radiological findings. The diagnosis was confirmed later on by histopathological analysis. Let's do a quick review of few take-home points on vestibular schwannoma. Vestibular schwannoma, also known as acoustic neuromas, are relatively common tumors that arise from vestibulocochlear nerve and represent approximately 80% of cerebropontine angle masses. On imaging, they classically present as solid nodular masses with intracanalicular component that often results in widening of porus acousticus. They usually show intense contrast enhancement, and when larger, cystic degeneration with hemorrhagic areas are common, but calcification is rare. This tumor most frequently arises from Schwann cells involving vestibular portion of vestibulocochlear nerve. Usual incidence is seen between 4 to 6 decades of life. The typical presentation of adult onset sensory neural hearing loss with non-pulsatile tinnitus. In some patients, this goes unnoticed and presentation is delayed until symptoms related to mass effect surface, such as cerebellar and brainstem symptoms due to cranial nerve dysfunction other than vestibulocochlear nerve and obstructive hydrocephalus due to effacement of fourth ventricle. Bilateral vestibular schwannoma are strongly suggestive of neurofibromatosis type 2. On histopathological analysis, the lesion shows antennae A and antennae B bodies and usually stains positive for S100 protein. Various other differentials to be considered in case of cerebellopontine masses are meningioma, epidermoid cyst, metastasis and ependymoma. Overall recurrence of the tumor after surgical excision is low. Observation and follow-up scans are advised for smaller lesions which exhibit minimal symptoms. For significantly symptomatic and larger lesions, stereotactic radiosurgery or microsurgery can be opted. Thank you.